second case report. The second presentation is also a case report. So this is a case of a probable advanced ovarian malignancy versus advanced gonadal tuberculosis. So I had this lady, 26 years old, nulliparous, next, who presented with 2 months history of severe right iliac fossa pain. So this patient was 26 years old. Meskia your age, 26, nulliparous, 2 months history of severe iliac fossa pain. She had a rapid weight loss of more than 15 kilograms over a span of 3 to 4 months. In fact, the cousins told me that they couldn't identify her during that Christmas holiday. That was last year. She had really lost weight. She had a large right iliac fossa mass, and I also noted that she also had multiple breast masses, which she complained about also, and I examined. She reported a history of dysmenorrhea that was not really significant for her, because she had kind of gotten used to it. She was like, yeah, I have painful periods, but it's not nimezoea kutoka high school, okay? No contraceptive use ever. She was an unmarried, nulliparous woman, and have never been screened for cervical cancer. Next. Oh, I'm going to push the car. Okay. So the clinical examinations, she was pale. She looked like somebody who had really lost weight, and she had a fixed pelvic mass that was quite large, 15 by 15 centimeters. On ultrasound, we found a complex multiseptated adnexal mass with some ascites. CT scan said there were bilateral ovarian masses that had kind of matted together into one with bowel and bladder involvement. And CA125 was elevated to 158. What would you think at this stage? Intern? What? What is your differential diagnosis at this stage? She's lost weight, CA125 is elevated. She has these large masses that now we are learning they're bilateral. Right? Everybody thinks it's cancer, right? Okay, to cancer. So my differential diagnosis was number 1, advanced ovarian malignancy. Remember, she had really lost weight. I could literally see her cheekbones, yeah? Or severe gonadal tuberculosis. So surgical findings, I did the surgery myself. I did it via subumbilical midline incision because I didn't know what I was going to expect inside. So intern, you don't go through funny steel for such cases. You go through SUMI. So she had ascites with bilateral pus-like ovarian masses matched to the uterus and the bladder. The appendix and omentum were densely adherent to the masses. Okay, so this screams cancer, right? So as I was trying to get my anatomy, there was a rupture of these masses, and there was brownish, false-smelling, purulent material that came out. So there was really no ovarian tissue. It was just bags of ovaries with this pus-like material inside. So they're really, I would describe them as empty ovarian cavities filled with this purulent material. And the ovaries were densely adherent to the uterus. I couldn't get the plane. I couldn't know where to cut to remove the ovaries and separate from the uterus, but everything was matted together. Yeah. So you can see there, I think I took a video of the same. Let's see if I can play it. When I play video, I'll be happy. How do I play the video? I press enter. It's just moving to the next slide. Anyway, but that's what I saw, and so I did a TAH, and she really bled. You can see all that blood, yeah? But gladly, we were well prepared. We had like 4 pints ready. So we did a TAH, BSO. Of course, cancer care says do omentectomy for ovarian masses. So we did an omentectomy, appendectomy, because everything was matted together. Primary debulking, of course, yeah. It was very difficult to dissect because the anatomy was really distorted. So I just kept medial. Because you don't know where the ureter is, so you just keep medial, okay? I was unable to get clear surgical planes. The bladder masses were left intact because the masses were involving the entire dome of the bladder. So I figured if I removed these bladder masses, then I would leave the bladder literally, 50% off and open. I wouldn't know how to repair this bladder. So we transfused the patient intra-op due to significant blood loss during the dissections. And after we did the abdominal surgery, we also excised the breast masses. So histology results what do you think the histology came out as? It was very surprising, actually. I had to call the pathologist and tell him to check again and be sure. This time I had counseled the patient thoroughly about the high risk of, the probability of ovarian carcinoma and need for possible chemotherapy, because we didn't do a proper debulking because we left the bladder masses intact, yeah? But surprisingly, the histology result came back as florid ovarian, tubal, and appendical endometriosis. Okay, so how do you start explaining to this patient and the mother that you are 26 years old, nulliparous, we have removed the uterus, KMPDC, but what would you do in such a situation with such masses? But you wouldn't have thought that it was endometriosis, And I remember asking about the history of dysmenorrhea. She was like, yeah, inakuaga, but it's not much. So the benign endometrial glands and stromal tissue with hemorrhage, also had some fibroids identified, and the breast masses were confirmed as fibroadenomas. No evidence of malignancy. This was checked by 4 pathologists. No evidence of malignancy. So this is the report that I got for the patient: florid ovarian, tubal, and appendical endometriosis. So postoperatively, I think this should have been done before the result. Post-op was very uneventful. The funny thing is that these patients who have very, very intense surgeries tend to recover very fast. You see them walking on the corridors and you're surprised, okay? So it was uneventful, minimal pain. She passed stool day 2. And the passing stool was very important for me because, remember, everything was matted together. The gut was matted there. And she was discharged on day 4. So, of course, we discussed the histology results after those 2-3 weeks of waiting. And the patient was actually very relieved. When I got the results, I was very scared about a possible litigation case. But she was actually extremely relieved that it wasn't cancer. Yeah, so she said the fertility part, she will deal with it later. But as long as she's going to live and she's okay, that's all that mattered. So she complains of occasional hot flashes due to the surgical menopause. But we have counseled her thoroughly, and she's very positive on fertility implications. We've put her on calcium, and we're also on discussions about possible hormone replacement therapy as need arises. So discussion: endometriosis affects 5 to 15% of reproductive age women. And advanced endometriosis may actually mimic ovarian malignancy clinically and radiologically, and may infiltrate pelvic organs, including the bladder, bowel, and associated with chronic pains, infertility, anxiety, and impaired quality of life. But histology remains the definitive diagnostic modality. So key learning points: this is the first case of florid endometriosis that I'd ever seen. So severe florid endometriosis may actually mimic advanced ovarian malignancy. And CA125 elevation is not specific for malignancy, may be elevated in both benign and malignant gynecological conditions. Fertility sparing surgery may not always be feasible, like in this case. I literally had no surgical planes to say what is remaining behind and what is coming out. Comprehensive counseling and multidisciplinary care is very essential, and histopathology remains the cornerstone of confirming diagnosis of florid endometriosis. Of course, you know about endometriosis. I won't go into that, the pathology and what happens with endometriosis. But with endometriosis, remember, advanced endometriosis may also present with what our patient had: weight loss, cachexia, ascites, elevated CA125, and complex adnexal masses that might actually mimic ovarian cancer. So radiological findings such as multiloculated ovarian cyst, omental caking and involvement, bowel adhesions, and peritoneal thickening, like the case of our patient, can actually strongly suggest malignancy, even when it's florid endometriosis. So dense adhesions and inflammatory masses may infiltrate surrounding pelvic organs, like in her case, and intraoperatively, friable hemorrhagic tissue and extensive pelvic disease may closely resemble carcinoma. Yeah. So this case actually highlights the diagnostic challenge of differentiating severe endometriosis from advanced malignancy. So let's have it in our minds when young women present with pelvic masses and elevated CA125, let's be also careful to evaluate for potential benign differentials. So an early diagnosis and multidisciplinary management may help preserve fertility and reduce morbidity. Histopathology, as I say and repeat again, remains the gold standard for diagnosis, and comprehensive postoperative counseling is required regarding fertility, hormonal therapy, and long-term follow-up. So regarding the fibroadenomas, this patient had breast masses and they were quite large. So women with endometriosis, they have an altered hormonal milieu, which actually has the same histopathology with the onset of, or with what fuels endometriosis. So these patients are actually at a very high risk of benign masses, and they're also at a higher risk of breast malignancy. So let us have it in mind that patients with endometriosis are also at a risk for breast cancer due to the same hormonal milieu and that causes the endometrial lesions to grow in the first place. Yeah, those are my references.